Hi, everyone, and welcome to this week's Office Hours. I'm your host, Stuart Newsom, and I know we're all closing in on a holiday week, but before we break out the lawn chairs and the sparklers and enjoy some barbecue, I just wanted to take some time to unpack a headline that's caught the industry's attention and stirred up quite a few reactions along the way, and that is prior authorization reform. So if you've been anywhere near LinkedIn or maybe a healthcare news feed in the last few days, you've probably seen the announcement. There were major health plans organized by AHIP, which is the America's Health Insurance Plans Organization, and backed by CMS and the Department of Health and Human Services, made a voluntary pledge to transform the prior authorization process by 2027. Now, they're promising faster real-time decisions, streamlined electronic workflows, greater transparency, continuity of care when patients switch plans. And this all sounds well and good. And on the surface, it sounds like a game changer, actually. But if you're in this space, like patient access, maybe revenue cycle, front office, clinical operations, you name it, you may be feeling something very different. A mix of deja vu, if you will, some cautious hope, and maybe a fair amount of skepticism, and that's understandable. Well, today I want to break this down and talk about what was said and what it means and why it feels familiar and what we should be doing now while we wait again for real change. So, again, I'm flying solo here, so it might be a very short, abbreviated office hours. We'll take about maybe 15 minutes or so to kind of unpack this. So, what actually happened? So, let's zoom out for a moment. This announcement really didn't emerge from a vacuum. It landed after years of mounting frustration across the care continuum. Providers are tired, patients are confused, front office and access teams are overwhelmed. So when the headlines hit, it wasn't just news, it was another chapter in a long story that we've all been living. So last week on June 23rd, U.S. Health and Human Services Secretary Robert F. Kennedy Jr. and CMS Director Mehmet Oz, affectionately known as Dr. Oz, stood behind AHIP and a coalition of major insurers, including United Healthcare, Aetna, Elevance Health, and Cigna, just to name a few, as they unveiled a new voluntary industry pledge to improve prior authorization. Now, the target implementation dates, now get this, January 1st, 2026 for preliminary milestones. That's just 6 months away. And January 1, 2027 for a full implementation. So here are the major comments in more detail. So we'll go over it. And if you've read about this, it may be redundant to you. We're just going to review, okay? But by 2026, health plans pledge to begin implementing automated decision-making tools and increase transparency in denial rationales and standardize electronic prior auth submissions. Now, by 2027, they commit that 80% of complete prior authorization requests will receive real-time decisions. And yes, you heard real-time decisions, 80%. They're looking to standardize electronic prior authorization workflows and will be adopted across all participating plans. So all plans are going to agree to this initiative. So plans will provide also clear, actionable denial reasons and ensure a 90-day continuation of care when patients switch insurance coverage. Now, anybody that's been in denials management from a claims perspective know those denial reasons may be vague and ambiguous. So here again, like more of the good stuff, right? So there's also a promise to collaborate with provider groups and reduce the use of prior authorization in scenarios where it's consistently approved. Now, the announcement includes aspirational language about embracing interoperability standards, leveraging APIs, and employing AI-powered tools that streamline the process. But let's not forget the key word here. This is a voluntary pledge. There's no federal regulation, there's no penalties, there's no required oversight body enforcing compliance. CMS says it will monitor progress and support accountability, but there's no binding authority compelling health plans to meet these goals, which raises the question, does a promise carry enough weight to drive real change in a process this entrenched? And it's a fair question, but here's another one worth asking. Is this announcement historic? Well, it might look like it is on the surface, but the fact is that health plans are making this public commitment together is noteworthy. It's certainly high profile, backed by two of the most visible government leaders in healthcare today, but let's not confuse visibility with viability. Now, Anders Gilberg, he's the Senior Vice President of Government Affairs at MGMA. That's the Medical Group Management Association. And he summed it up well. And I quote, "We've seen this movie before." Now, Gilberg was referring to the prior 2018 commitment made by a group of payers and providers under the banner of the consensus statement on improving the prior authorization process. Now, that effort also promised streamlined workflows, reduced volume of authorizations, and transparency in decisions. Sounds familiar, doesn't it? Yet 7 years later, most providers would argue that not much has changed. So Gilbert continued, and I quote again, "MGMA and our members have long supported efforts to reduce the burden of prior authorization, but we remain cautious until we see concrete action." So other organizations weighed in as well. So you have the American Medical Association. In a press release, they said that they support the intent, but they emphasize the need for enforceable guardrails. And I quote, "This is a step in the right direction, but the public deserves more than corporate assurances." And then you look at the Senior VP of Government Affairs at Premier Inc., which is Sumi Saha, echoed that sentiment. So that voluntary pledges aren't the same as enforceable protections. Patients and providers deserve more than promises. They deserve accountability. And then you have the American Hospital Association and HFMA. Both expressed cautious optimism, but highlighted the critical need for regulatory oversight and enforcement to achieve sustainable change. So you see a pattern here. So is this historic? Well, maybe, but we've had historic sounding headlines before. And until we see something more binding than a press release, the general sentiment remains one of skepticism. So this isn't the first time the industry has promised to fix prior authorization. Now, we mentioned it earlier, and that was the 2018 consensus statement on improving the prior authorization process. It's worth revisiting now. So because it was supposed to be a turning point in this whole process. So back then, major providers and payer organizations, including the AMA, the AHA, AHIP, and the Blue Cross Blue Shield Association, came together with shared goals. They wanted to reduce unnecessary prior auth requirements, improve transparency, and speed up decision times. Then you had the Da Vinci Project, and that's a private sector initiative that fell under HL7, also emerged with high hopes. It focused on creating FHIR-based standards for prior authorization and other administrative tasks. Now, for those of you who don't know what FHIR is, it's not FIRE, it's FHIR, stands for Fast Healthcare Interoperability Resources. And the vision for this was interoperability, a seamless exchange of data that would eliminate faxes and PDFs and usher in real-time automated approvals. Now, how many of you still deal with faxes regarding referrals, orders, medical records, and insurance information? I've talked to quite a few people and they're dealing with them on a daily basis, into the thousands. Now, then came the CMS Interoperability and Prior Authorization Final Rule, which was finalized early in 2024. It mandates that payers in Medicare Advantage, Medicaid, and CHIP programs build APIs for electronic prior authorization processes by 2027. Now, each initiative was well intentioned, each sounded promising, yet here we are in 2025 with many of the same burdens in place: manual faxes, long delays, and confusing denials. So, the takeaway, well, we've been down this road before. As Gilbert said, we've seen this movie before. So, we've just touched on one of the more significant initiatives, and I want to go back to it, and that is the CMS Interoperability and Prior Authorization Final Rule, which was again finalized in early 2024. But it deserves a closer look because, unlike voluntary pledges, this rule actually has some teeth. This rule requires implementation of several new capabilities, again by 2027. You have FHIR enabled APIs must be implemented for prior authorization, patient access, and provider access. Payers must respond to prior authorization requests within 72 hours for urgent requests and 7 calendar days for standard ones. They must provide specific denial reasons, and they are expected to publicly report metrics on prior authorization performance. Now imagine that, actual metrics on the performance. Now, unlike the recent AHIP pledge, this rule is federally mandated, enforceable, and subject to compliance measures. But it only applies to a subset of payers. primarily those in public programs. Commercial insurance aren't currently held to the same standards, and while CMS hopes the private sector follows suit, there's no guarantee they will, which means a large breadth of the market remains in voluntary territory again. So let's talk about what's actually broken. Now, in conversations with our clients, from imaging centers to specialty clinics to large hospital systems, the prior authorization process consistently emerges as a workflow nightmare. And a big part of the problem is workflow. It's very slow, it's cumbersome, and to say that is an understatement. So here are just a few recurring pain points. Number one, fax request. Many prior auths still start with faxes, leading to errors, delays, and follow-ups. Manual re-entry. Staff re-enters the same data into multiple portals. It's inefficient and error-prone. Lack of status updates. There's often no visibility into where an auth request stands, leading to phone calls, confusion, and resubmissions. Then there's delayed inpatient care. Approvals take too long, procedures are postponed, and patients just end up canceling the appointment. Disconnected systems. This is clinical systems that really don't talk to each other. They don't talk to rev cycle systems, and then prior auth teams operate typically in silos. And then there's inconsistent criteria, and this is where the approval criteria vary between payers and are often obscure if they're available. Now, all of this isn't just annoying; it's costly. It burns staff hours, delays revenue, and most importantly, impacts patient care. We were told interoperability would fix this. Standards like FHIR and APIs like those from the Da Vinci project were supposed to eliminate these gaps. But adoption has been slow, and many vendors still don't support the interoperability. Until there's an alignment between these systems and standards and stakeholders, these issues will persist. So, are these pledges just another round of empty promises? Well, there's reason to be skeptical, but we've heard it all before. Faster decisions, less paperwork, regulation, we've seen how this can be very slow or non-existent, and actually how lack of change there is. Now, payers have little incentive to accelerate care approvals. In fact, some critics argue that delaying approvals is part of the business model, a way to manage cost and reduce utilization. A voluntary promise, no matter how well worded, doesn't fix that misalignment. It doesn't guarantee that vendors will cooperate, that insurers will follow through, or that patients will be better served. Accountability is missing, and that's the core issue. So, what does this all mean? Well, at best, the AHIP led pledge is a signal. It shows that payers are actually aware of the pressure, that providers, patients, lawmakers, and regulations are no longer staying quiet about the pains. So, they're at least listening due to the persistence of everyone that's involved. It also shows that vendors like Availity, Change Healthcare, and others see a business case in solving the prior auth problem. There's momentum here, and that shouldn't be ignored. But the pledge by itself doesn't change anything yet. The real work is in execution, in closing the gap between what's been promised and what's been delivered. So we can acknowledge this moment is important, but we shouldn't let it distract from what still isn't working. So what should we do now, especially those of us in the trenches? So here's what I typically recommend. First of all, stay informed and alert. Don't just glance at the headlines. Monitor how these pledges unfold over time. Which insurers release action plans? Who hits their 2026 and 2027 targets? And who goes quiet? Subscribe to newsletters, follow regulatory updates, and keep an eye on what CMS does next. If there's a gap between the pledge and practice, it's up to us to name it. Then ask harder questions. When engaging with payers, vendors, or even internal stakeholders, go deeper. Does this new solution reduce clicks for your staff? Does it eliminate faxes? Is it really interoperable? Or is it just marketing speak? Be ruthless about alignment. It doesn't reduce administrative burden and improve patient experience, then it's not enough. And the next, hold vendors and partners accountable. Ask your clearinghouse, are they aligned with the Da Vinci project? Are they building the infrastructure that supports real-time data exchange? Are they helping you meet the CMS final rule requirements? Don't assume that participation in the pledge equals actual effort. Push for updates, proof points, and integration timelines. And then next, test what you can control. No matter how large or small your organization, there are incremental steps that you can actually take. Automate where possible, use denial analytics to isolate trends, partner with IT or rev cycle teams to reduce manual entry, track how long it takes from auth submission to decision, create baseline data and use it to advocate for tools or change. Now, also, you want to be a voice for change. I always say decisions are made for those who show up. So you need to speak up, talk about what's broken, share your stories internally and externally. Industry change tends to follow visibility, and the more public pressure, the more urgency. So whether you're in a physician group, imaging center, or hospital or tech vendor, your perspective matters. So let it be heard, and then prepare for what's next. And this final point is very crucial. Don't wait until 2027. If you're making tech investments or planning strategic initiatives now, build with future requirements in mind. Even if commercial payers lag behind CMS, you can future-proof your workflows by adopting API-ready platforms and vendor-agnostic tools today. The pledge may not change the game overnight, but you still have a role to play. You all remember that Peanuts cartoon, right? With Lucy holding the football. Charlie Brown runs up to kick it and she yanks it away at the last second and he falls flat on his back in pain and agony. Now, that's what this moment feels like for many of us in healthcare. Another promise, another pledge, another headline telling us relief is on the way, only to watch it vanish when it comes time to act. But Charlie Brown always gets back up. And I've always wondered why. Well, maybe that's naive. Maybe that's just who we are in this field: persistent, hopeful, tired, but not done. And maybe, just maybe, this time we keep our eyes wide open and hold the system accountable, not just for better workflows, but for better care. So let's bring it all home. This pledge, it's not regulation, it's not enforcement, it's not a guaranteed fix, but it is an opportunity to push for change we want, which is smarter automation, stronger interoperability, fewer roadblocks for providers, and faster, clearer decisions for patients. And we can't let this moment pass without scrutiny, without urgency, without our voices at the table. So before we sign off, I hope you'll join me next week for a new episode of Office Hours. It's titled From Facts to Future in Radiology Prior Authorization Workflows. My guest will be our own product manager of automation, Charula Navdisha, and she is a healthcare product leader with deep experience in workflow automation. So we'll explore how radiology groups are using AI-driven tools to eliminate manual document capture and speed up prior authorizations from moments a fax order arrives into the facility. Now, if your prior auths can't start until someone opens a fax, this one's for you. So we're really going to focus on the issues, the problems that we see and hear in this actual arena. And if you haven't already, check out our podcast, Revenue Cycle Optimized. We cover topics like today's discussion in short, actionable episodes that you can actually keep up with. So subscribe on your favorite platform and never miss an insight. So I want to thank everyone for spending time with me today. Have a safe and restful long weekend. And let's keep up pushing together for a system that works, not just one that promises it will. Happy 4th of July, and God bless America.